Tuberculosis is an infectious disease caused by Mycobacterium tuberculosis, which is an acid-fast organism. It was the leading cause of death in the United States until the introduction of anti-TB drugs, which usually came around in the 1940s and early 1950s. It's still on the rise, particularly among the population that has HIV/AIDS, the immigrant population, and individuals of low economic status. And it's associated with poverty due to malnutrition, overcrowding, inadequate health care, and those types of issues. Worldwide, it infects approximately 1/3 of the entire world's population, which is almost 2 billion people. And there were about 20,000 new cases of TB reported to the CDC in the late 1990s alone. So it shows you the prevalence of this particular disease. Of the people that develop or actually are exposed to tuberculosis, 9 out of 10 of those people never will develop the active disease itself. So we're going to talk a little bit about that information. The nursing situation for the TB lecture includes a patient who is a 21-year-old female who's completing her health requirements for entrance into nursing school. She has had all of her blood draws done and has started her hepatitis series. She's been injected for the first of the 2-step of the PPDs and is waiting for her results. When we talk about how TB is transmitted, it's an airborne droplet infection type of transmission, so it is spread person to person through coughing, sneezing, speaking, laughing, singing, those types of things. So what happens with this is the person that develops TB can shed it to other people, and if the other person's defense mechanisms and immune response are not that great, it puts them at more susceptibility for actually developing the tuberculosis infection and those types of things. So please read through your speaker notes. It gives a little bit more detail about what happens once the body is infected with tuberculosis and how some people will stay dormant with tuberculosis after they have been infected, and other people will develop the active disease. One person with active TB will actually infect 10 to 15 other people per year while they have an active TB. Those patients that are most at risk for contracting TB are those that are medically underserved, those that have other conditions that put them more at risk because their immune system is not working as effectively. And those types of patients would include patients that are alcoholics, IV drug users, HIV positive, patients who are immunosuppressed, and residents and staff of long-term health care facilities and others that live in crowded conditions and populations. As you all know, because of your health screening tests that you've had to get done in order to do clinicals, screening for tuberculosis is done by the MAN2 TB test. It's injected intradermally. It's a very small amount of the medication, only a 0.1 ml amount of the PPD is actually injected. As you remember the last time you got one, it forms a wheal once it's injected, and then we look to see if there's an area of induration after about 48 hours that the area was injected. And that can indicate that that patient had a positive reaction to a PPD. So once again, 48 to 72 hours after the injection was given, the patient is brought back if it's an outpatient setting, or if they receive it while they're inpatient, it'll be on the medication administration record. But that patient is then checked to look for a hardened area or what we call an area of induration at the site of the PPD. So healthcare workers that have had exposure to a patient that's had TB on their particular health unit should actually have the TB test done 8 to 12 weeks after exposure, because it takes that long to develop the antibodies to the TB. And it would take this long to convert a negative TB to a positive one. As we spoke earlier in the lecture, usually after exposure, only about 1 out of every 10 people will ever develop active TB, even though they've been exposed to tuberculosis. Most patients with TB have it in a dormant state. They're asymptomatic, and when it's in a dormant state, then they are not infectious to other people. So they're only infective when the TB is in an active state. So how does the patient know if the injection was positive? The area of induration is going to let that be known. Just the fact that it turned a little bit red around the site is not going to indicate a positive PPD. There actually has to be that hardened area, the indurated area around the site of the PPD. So 0 to 4 millimeters enlargement or induration means that that patient has little or no sensitivity. However, if their history indicates exposure, the test may need to be repeated about 4 to 6 weeks later. A 5 to 9 millimeter area of induration indicates a doubtful reaction, and testing may be required. However, if that patient is HIV positive or has AIDS and has a 5 to 9 millimeter reaction, then they will probably just go ahead and get a chest x-ray to look for any signs and symptoms of dormant or active TB. Typically the scenario is if that patient has a 10 millimeter area of induration, that's highly significant for a past or present infection from tuberculosis. And remember, any patients that have received the BCG vaccine, which is actually the tuberculosis vaccine, it's given very commonly in Europe and Latin American countries. These patients will also test positive on their PPDs when they receive that vaccine. For our case scenarios that we talked about earlier, we're going to say that this nursing student noted 3 days after the injection that the skin measured 30 millimeters. And what does this mean? So in this particular instance, yes, this means that this patient definitely had a positive reaction to the PPD. However, it does not confirm that that patient has active tuberculosis going on. So in other words, the patient, yes, has had exposure, and yes, has developed antibodies, but we don't know that that patient has an active case of tuberculosis. So what's going to happen next is that patient's going to go ahead and get a chest x-ray done. So the patient will be examined to look at the social history. In other words, do they indeed fit some of the criteria of that we talked about earlier, living in crowded conditions, malnutrition, have some of those other issues we talked about on. Look and see what the possible exposure could have been, names of close contacts, look and see if the patient has any signs and symptoms of active tuberculosis infection, if the patient's on any other medications, and look at what that patient's access to health care is. The patient with that 30 millimeter reaction to the PPD would have a chest x-ray done, and the patient may also need, if the patient has symptoms of tuberculosis, may need sputum smears and cultures, and that's going to be the definitive diagnosis for tuberculosis, along with the signs and symptoms the patient may have. Typically those cultures are not rapidly available. It usually takes about anywhere from 3 to 6 weeks to grow out those bacterial cultures for TB. So typically patients are gone ahead, and if they have signs and symptoms of TB and a positive PPD and a positive chest x-ray, then they're going to go ahead and start them on the medications for TB. So this shows a chest x-ray of a patient that does have TB. So it shows you those caseated areas that are noted within the lung tissue for a patient that does have active TB. And refer to your textbook for further information on the pathophysiology of what goes on for a patient that has active TB. We talk about patients that develop TB infection versus TB disease. TB infection is also known as latent TB. This is where the actual area of tuberculosis is in a dormant, inactive state. It's walled off within the lung and that type of a thing. And versus patients that have active TB, which is the disease itself, will actually show signs and symptoms of the tuberculosis illness being present. So symptoms of TB that occur several years after the primary infection are known as reactivation of TB. This just shows you some examples of lung tissue of a patient with TB versus a patient with healthy lung. The typical signs and symptoms that a patient with tuberculosis will exhibit include blood-streaked sputum, a productive cough, night sweats. The patient may have chills and pallor, a low-grade fever. It's very common for those patients to have an afternoon temperature elevation, to feel very fatigued, to have anorexia, have weight loss, and the patients may also complain of dyspnea and chest pain, particularly also in the later patho changes with the disease. Preventative therapy for TB, in other words, for those patients that have a positive reaction and do show that there's some changes on the chest x-ray, those patients are going to go ahead and be placed on isoniazid, which is also known as INH, typically for 6 to 12 months. Some side effects of this particular drug include fever, chills, rash, and neuritis. So these patients are typically given a vitamin supplement of vitamin B6 to help with the neuritis types of side effects that happen with this particular drug. Because it can be very toxic to the liver, patients on INH should also be checked for liver enzyme studies, BUN and creatinine levels to look at kidney function. Those should be pretty much checked, the livers and the kidneys, on a routine basis. And sputum culture results may be monitored to evaluate the effectiveness of the treatment if the patient does have active TB and this is one of their medications that they're on. If they do have active tuberculosis, they're going to be more than likely placed on many different medications. They're not going to be placed on just INH alone. Typically, during the first 2 months of treatments, if the patient has active TB, the patient's going to receive INH, rifampin, and pyrazinamide, and either a fourth medication, which will be either ethambutol or streptomycin. And typically, those patients continue that medication for a total of about 6 months altogether. Usually they take the INH, rifampin, and pyrazinamide daily for about 2 months, and then they take the INH and rifampin for about 4 more months after that. So please review your readings in your textbook to look at side effects of these drugs and to also look at typical scenarios of how patients take these drugs in combination, because there are some that can actually combine different types of meds. The first one listed there, Rifader drug, that one actually combines INH, rifampin, and pyrazinamide, and the Rifamate is a combination of the rifampin and the INH. So it just helps with drug compliance on these patients that have to take multiple medications for a long period of time. If these drugs are taken uninterrupted, in other words, they're taken as they are prescribed, usually that sputum will convert to negative within about 2 to 3 weeks. So when that patient's retested again to see if they are still shedding tuberculosis or not. So it takes them about that long so that they're not actively shedding that and infecting other people. Other public health follow-ups are to do skin tests, PPDs on all household members. And for those patients that they may be worried if the patient's not going to be compliant with taking the medication regimen. If they do have active tuberculosis, then that patient may be involved in a direct observational therapy program, which means they have to come to an outpatient clinic for their daily medication administration. And if they do not show up, then there will be consequences for that. So that's known as direct observation therapy. Follow-up PPDs. If the person, most individuals who develop TB and an infection don't develop an active case of TB, we talked about that earlier. All it shows is if that person has a positive PPD, it just shows that they have, they've been sensitized and have formed the antibodies, but it doesn't necessarily mean that they're going to be positive. If their immune system would change and they would become to a point where they would be immunosuppressed, this person could possibly develop active TB later on in life. So that's why they're treated with the prophylactic INH. When we look at protection of healthcare workers, TB precautions include the use of a respirator, or it's called a HEPA filter mask. If healthcare workers are going to take care of patients with active tuberculosis, they need to be fitted with one of these special masks. They're rather expensive, so we've had some instances in clinical where nursing students were not allowed to take care of patients with active tuberculosis just because it's rather costly to have these fitted for all the different nursing students that rotate through a unit. These patients are placed in respiratory isolation. They receive routine testing, and anybody taking care of patients on a respiratory floor where you might have quite a large population of active TB patients should have their TB tested on a regular basis to make sure that to look at exposure history and those types of things. As far as the respiratory isolation, the patient should be placed in a private negative pressure room with the door to the hallway closed to help to decrease the risks for exposure to other people and those types of things. And then obviously personnel need to wear disposable gowns and that type of a thing. They need to be in respiratory isolation. As far as some quick questions on TB, here's some true or false questions. Most tuberculosis patients become non-infectious after 2 to 3 weeks of treatment. This is actually true as long as those patients have continuous medication therapy that they have been adhering to. The second line says drug-resistant tuberculosis cannot be cured. This is false. There's actually a whole gamut of different drugs that are out there on the market. So patients that have developed drug resistance to INH, pyrazinamide, and rifampin, those types of drugs, there are other drugs on the market that can be tried. TB drugs may produce side effects in some patients. Definitely, we've talked about a lot of them have many, many different types of side effects. So refer to your textbook for those side effects. And the best room assignment for a person with TB is in a private room. This would be false. They needed to be in that negative airflow pressure that has air that can be rerouted to the outside. And drug therapy for TB patients usually lasts about a month. This is false. It lasts usually on an average 6 months. And if that patient's HIV positive, then that patient may need drug therapy that lasts closer to 12 months. People with TB infections cannot infect others. We already know that's a definite false. Any mask is acceptable when caring for a patient suspected of known to have active TB. This is false. The healthcare worker needs to be fitted with a HEPA filter mask. And the last one, people with HIV undergo the same TB treatment as those without HIV. And this is false. Typically, HIV patients are treated for an average of 9 to 12 months. And they may be on an additional drug therapy program for 6 months after their sputum has converted to negative. So here is an NCLEX question on TB. So I will let you read through that, and the correct answer is actually on the speaker notes.